Hi, I'm Joanne Lynn. I'm a physician, a geriatrician. I was one of the first hospice doctors. I served Washington, D.C. for many years. I've taken care of about 2,000 people who've died, almost entirely in nursing homes, home care, and hospice care. So my experience is a little different. I actually oppose the legalization of physician-assisted suicide, but not the practice, because my patients have not yet been considered. And I'll show you a little bit why in this conversation about terminal illness. So what is it that we want to do with this category of terminal illness? David was just saying how much turns on it. We want a workable category of people who are entitled to certain things that the rest of us are not. And right now that includes hospice care and physician, I guess I have to say physician aid in death in this workshop. I still find that a hard one to do. Three key components. Person has to be competent, acting voluntarily, and have a terminal illness. And the terminal illness piece is what I'm going to talk about here for a short time. We have institutionalized that as predicted to die within 6 months. The 6-month criterion arose on the floor of the Congress when Congress was passing the hospice statute. And it arose with no empirical evidence and with no hearings. So the basis of the policy was just we needed a something to make a divide. And someone suggested 6 months, and that's what got in the statute. So what is a prognosis to live for 6 months? What do you think? Anybody want to proffer one? Nearly certain to die within 6 months. I promise I'm leaving you within 6 months. Very likely to die. Okay, I might make it through, but pretty much I'm gone in 6 months. Or 51% of people just like me will be dead within 6 months. 49% will live on. What's the standard here? Sounds like kind of an academic, head of a pin argument, right? No way. This one is huge. And it has been resisted in being defined throughout the entire persistence of the hospice legislation and throughout the arguments on physician aid in death. So we do not have a choice between these three. No one is telling me which one I'm supposed to apply. Now, I want to show you why that matters. First, a little about the course to death. All of the cases that we talk about in public about physician aid in dying, or even about dying generally, are, from my perspective, young people. Young as anybody under about 80, 85. And with a single dominant illness, with a highly predictable course. That's not how most of us will die. If you look at the people in this room, about a quarter over there of you would die with an illness like that. And the other 3/4 of us will die of a long-term, serious, debilitating illness. So the image we have as a culture is this image. Function or quality of life, something like that's on the y-axis and time's on the x-axis. And we're cruising along doing really pretty good, and then we get hit with a terminal illness and we decline and die. When I was growing up in West Virginia, people would say, you have to go visit Jim, he's failing now. And failing meant you didn't put it off for long. He was really on a dwindling course, he was losing weight, he was taking to bed, he was not going to last long. And that was the image we had for hospice. That was the image we had in mind for hospice care. And at the time, that was by far the most commonly commented on in our culture. Every Hallmark movie uses this. Almost every movie. You have to really search to find the alternative. But most of us will get a course more like this. Pretty crummy function, quality of life, whatever, for a long, long time. The median duration of self-care disability, you require someone else's help every day. The median length now is 2 years at the end of life. Most of us in the room will have 2 years or more. About 20% of us will have 5 years of requiring someone else's help on an everyday basis. What is dying like in this sort of course? You're walking a tightrope in a windstorm. Some people will hit a wind gust early and be gone. And some will somehow make it for a long, long time before they encounter that. I had a patient once with an ejection fraction of 4%. Those of you with medical backgrounds will recognize that's really pretty unlikely to survive. She made 2 years. I wrote the famous line in hospice prose when I was consulted because the feds wanted to kick her out of hospice. This patient has no way to demonstrate any worsening of her condition without being dead. She had the good fortune or the misfortune of having no grandchildren, so she never got exposed to a cold. She loved her soap operas and her television, so she had a bed-to-chair existence in a senior housing unit with food delivery. We had a hospice program calling her every day, reminding her to take her pills. She went on and on and on, and then one day she was dead. No particular illness. She had a prognosis of less than 6 months all that time. But when was she hospice eligible? When was she eligible for physician aid in death? All along? See, we haven't thought about kind of how people come to the end of life. So I'm going to compare these two courses. This is a stereotype, I'm sure, and there are middle ground issues and so forth. But just take the classic terminal illness course with going along just fine and then hitting the decline. There are many big-time cancers that actually pursue that course. Renal cell carcinoma, non-small cell lung cancer. So how long is a person self-care disabled? A few weeks. Not a long, long time. What's the error, in quotes, of surviving a year when you have a 6-month prognosis? Very few. There will be some people who make it past 6 months. There won't be very many still alive at a year. And the lead time to know that you have a nearly certain death within 6 months is a few weeks or months. You know, it's a little time. You can see the person's losing weight, taking to bed, doing badly, failing now, and everybody can gather and say their goodbyes. The dwindling course, on the other hand, has an average of 2 years of self-care disability. 25% or more will still be alive at a year. And the lead time for knowing that the person will die might be minutes, might be hours, certainly no more than a few days or weeks. So the person gets a bad cold, gets a pneumonia, maybe survives for a week that way and dies. But 3 weeks earlier, you couldn't have told that this was the month on which she would die. The survival curves, just to sort of stereotype, that bottom curve is the one for the classic course, and the top curve is the one for the more typical dwindling course. Does it matter that there is a substantial survival at 6 months, 12 months, 18 months? We haven't thought about that. What is a prognosis of 6 months if 20% of people live 2 years? So if you compare the two courses, I just want to walk you through. Can you hear me okay if I talk loud? No? So the dwindling course, the few days up to a week or two to know that the person is almost certain to die is the shortest time, just A. The person who has the pneumonia on top of being 94 and frail. Then the lead time to know that it's nearly certain for a person with lung cancer is somewhat longer, A plus B. But if it's more likely than not, the few additional weeks are A plus B plus C is something longer. And the longest time is the person with more likely than not who is with a dwindling course. That's the longest survival. So that makes it very complicated, and the number of people eligible will have X, whatever number, oh, that doesn't matter. Go ahead. The X with the nearly certain will be 10X if it's more likely than not. But look what happens with the dwindling course. You have less than X, some very small number eligible if you have to be absolutely certain. But if you just have to be more likely than not certain, my mother at 96 with her frailty counts. And my lady with her 3% ejection fraction counts for 2 years. So we haven't thought about what we really mean by which of these criteria are we really going to use. In addition, the predictive models are made with all manner of biases, and no one is supporting developing predictive models. So we're all working on hunch and intuition and not real data. So there's important research questions, and I've thrown a few of them up here. Why is it that we don't want to decide this? Why, on the many times I have thrown this at hospice, hospice has ducked and not wanted to have a criterion, even a more likely than not criterion, which would give them the biggest possible scope. When I put this into legislative hearings, no one wants to deal with it. I think we kind of want there to be this category. But it's really, really dangerous because we haven't thought about what that really means for the majority of us as we come to the end of life. There aren't entities ready to do the data work to develop the statistical prognoses. And how would we learn to talk about it with an ambiguous prognosis, which is statistically more likely than not to kill you within 6 months, but which is also one that you could survive with a long time? So just to throw into this conversation the serious question, what is it that we really mean by a prognosis of 6 months?